Welcome everybody to the Therapy Insights Resource Roadmap Show. This is where we get a chance to talk to the writers about all of the new resources that we've just added to the library. And we have Troy and Ross here with us today to talk about all the different creative ways to use those resources and some of the evidence behind the content that we create. So we're going to go ahead and dive right in. I'm going to share my screen so we can see the resources as we talk about them. And the first resource we have is How to Tape for Lateral Ankle Sprains. It's a 2-page resource that has a lot of great images, step-by-step instructions for how to do this. So Ross, tell us a little more about this resource.
Yeah, so this resource, I was thinking a lot of us learn some tape techniques in school or during internship training, but then if you don't regularly work with people with ankle sprains, you can easily forget how to do some of these things. And so having kind of a step-by-step guide for taping the ankle can be helpful in those instances. And I decided to write about the figure of 6 ankle tape job. It's one that I've been using personally with a client who has a rare neurological disorder called ARTS syndrome, and he has a lot of inversion with his ankle when he walks, and this seems to stabilize his ankle. And it's a less bulky tape job than the traditional figure of 8 tape job that's commonly used. And there's some research showing that it actually does, this research looking at athletes showing that it does actually alter the mechanics of the ankle when you land on the ankle. So it actually does provide some support to the ankle. So essentially it goes through your step-by-step instructions. So typically you want to shave the ankle, cover with an adhesive spray. You can use pre-wrap if you want to protect the skin even more. And then you keep the foot in neutral dorsiflexion the entire time. And you use just a regular athletic tape works fine for this. And essentially you form a figure of 6 with step 4A. You can see how you start on the top of the foot, you work down medially, then wrap around to the side of the ankle, come across the front in front of the lateral malleolus, and then you end kind of near the lateral ankle. And then you can do 2 or 3 straps like that, overlapping a little bit as you go. And then on the next page, if you look at 5A, you can do the heel lock, which so the initial figure of 6 on that we went over on that first page prevents, it kind of pulls the foot into a more everted position, and then the heel lock will kind of keep it from rolling the other direction. So you start on the front of the ankle, you work laterally, then wrap back inward over the medial heel, and then you end on the top of the foot. And it's kind of the same where you can do multiple straps if you want to provide extra stability. And then you can apply anchors over the top of those to hold everything in place. And you can actually provide a figure of 8 over the top if you want, but the downside of the figure of 8 is it is a bulkier tape job. And of course, this is just my clinical experience, but I found that it's also harder on the skin, I think, than this one, because this was a less bulky tape job. So.
Great. And then you also, was that the one that tied in with the article snapshot?
Yeah, it did. The article snapshot, I was looking at one question that we frequently have in PTs. There's a lot of different types of tape that can be used to support the ankle. You can use regular athletic tape, which is what they used in that other study with the figure of 6. You can use Leuco tape, which is an even stronger rigid tape, or you can use Kinesio tape or rock tape, which are your stretchy tapes. And that other study that used the figure of 6 actually did find that it was successful in changing mechanics at the ankle with landing. I looked at another study that was looking at Kinesio tape, and essentially they took, I think it was around 30 healthy people, and they did EMG analysis of different muscle groups. They had them on a tilt board, and essentially they had 4 different conditions. One was shoes with no tape, one was shoes with tape, one was just tape barefoot, one was barefoot with no tape. And they had this tilt board move in different directions, and they looked at the latency of activation of the muscle and the overall activation of different muscles around the ankle to see if the tape affected proprioception and stability of the ankle. And what they found was that shoes actually decrease the latency of the peroneals, which you don't want, since the peroneals are your most important muscles for preventing an inversion ankle sprain. And they thought that might be because of decreased sensory input with the use of shoes. The overall activity of the peroneus longus and tibialis anterior was increased, so that's kind of counterintuitive, but there's a difference between activating when you want to activate and just having a lot of activation. So shoes did increase overall activation, just not necessarily when you want it. A lot of that was just because the shoes might actually tilt the foot a little bit into inversion. So you just kind of have more resting tone of the peroneals with that. And so the kinesio tape basically did not do anything for support or proprioceptive activity. Though one thing to keep in mind is that this was all healthy individuals, so it's possible that the results would have been different in people with ankle sprains. But I thought it was an interesting study and definitely applicable to that tape piece for sure.
Great. Thank you. Okay, I'm going to skip back to the next resource, which is, I love this resource. It's a 2-page resource all about home modification for individuals who use wheelchairs, specifically looking at doors. And Troy, can you tell us more about this piece?
Yeah, great. Yeah, so exactly. It's for folks that have, where I envision clinicians using this is for someone that has, acquired a recent injury or trauma of some sort that's going to require long-term use of a manual wheelchair or a power wheelchair, I suppose. And often with discharge planning and things like that, there's a lot that goes into home modification. So this is just one piece of what's really going to be involved in appropriate home modification for someone that uses a wheelchair. And specifically with the doorways, what we cover with this piece, it kind of breaks down what are the ways that first you go home and assess, are these doorways going to be adequate? So it kind of talks about what we call clear space versus thresholds versus door stops and things like that, and what we can do to modify the door. So goes through some kind of basic examples of how to modify to some more complex ones that might require maybe some home carpentry or even some modifications that require, a professional carpenter as well. So the first option that a lot of people will sometimes use is to pick up clear space is you just remove the door. So with a standard hinge, the door swings open, and you'll lose about, maybe 1.5 to 2 inches of clear space of where a chair could roll through that door because of the way that the door hinges work. So if you just need a little, that's simple, right? You just pop off the hinges and you're ready to go. Now that's complicated, right? If maybe this is into a bathroom or a bedroom or something like that, where you want some more privacy, might not be as good of an option, but maybe you live alone or with a caregiver and you don't mind that, then that works great. So that's one option. The other option that can pick you up just a little bit of space is you can, that requires just some simple carpentry, would be removing the door stop. So the door stop is the portion of the door that's next to the handle that's actually on the frame, the door frame, not the door itself. And people will just take pretty much just a saw and cut off that small piece of door stop below the height of the chair. So you can still keep a lot of the door stop intact. So it's going to be able to close, relatively tight and things like that, not rattle or not push through, but you just cut off that last little bit. That really, though, that's only going to pick you up maybe 1/2 inch at most. So, but that can help if you need more. Another recommendation they make, they're called swing away hinges. They look a little different. You probably have to special order them, but they're not expensive. And what this does is the hinge is a lot bigger. You can install it in the same way you would have with the door, but as you swing it open, it will remove the width or the depth, I guess, of the door into the clear space on the other side of the room to which the door is opening. So it opens up that space as well. You can still keep it closed. Yeah, so that's a good option. Also, you can widen the door, right? So that's the most expensive option, but it kind of takes a patient through. These are your reasonable resources here to make this this home or this space a little bit more appropriate. It also gives some recommendations in terms of what the American Disabilities Act or Americans with Disabilities Act suggests as well in terms of width, so that you can kind of build it standard to that. So maybe you're even setting up this space as a place for maybe your aging parents or something along those lines, and you want to make a space that's ADA accessible. This will give you some ideas on that and what's required for doorways. The other half of the resource is about thresholds and door handles. So it breaks down what's required for ADA in terms of thresholds, how you can modify a threshold. There's some simple options, which is you just get they make a mat that is a ramped mat, more or less, that you can put over the top of the threshold or up next to the threshold, so that it's just a smooth ramp into the door or into the next room. Or you can build an actual beveled threshold so that when those front caster wheels are trying to make it through the doorway, they're not getting hung up or if you're going quick and you hit something with your front casters and you're not able to get over it, that can be an issue of safety. And the last piece is modifications of door handles. So probably the best solution is you just install handles that have levers. If that's not something that is doable in your home, whether you have a kind of a vintage classic look in your home and you don't want to replace the handles or things like that, there are aftermarket products that you can fasten to a door to give it to make that doorknob into a lever or something very similar, so that it can ideally be opened with one hand is really the goal, or with weak grip strength. So for someone that's maybe using a wheelchair that has weak strength, maybe someone that has a cervical level spinal cord injury where they don't have good hand function, this is really, really helpful for them. So a nice resource though for anybody that's kind of in the initial phases of home modification. And often, right, it's a little bit of a frenzy for caregivers and family members, right? They've just often had somebody that's going to have significantly different physical abilities, and they're in the hospital or in a nursing facility or something like that, and maybe you're trying to get them home. And so often this stuff is really, really important. It's really built to be like, hey, here you go. If you have some carpentry skills, like these are some good options of some stuff that you can do tonight or this week or whatever to get a loved one back into their home environment. So
yeah, great. Thank you. I mean, my wish is that all homes would be required to have universal design elements as far as like the width of the doors and accessibility considerations, but that is not the case, even though we have a lot of building codes in this country.
Yeah, absolutely. And a lot of homes that are older homes, especially, you'll run into issues with this where you got a door frame that's just like not doable in any way. And
mobile homes, modular homes.
So
yeah, great. Thank you. Okay, we'll move on to the next resource, which is a 4-page resource. I believe I broke it up into 2 different slides. So as we talk about it, I can go to the next one. This is a reference for clinicians all about diagnostic metrics simplified. So you've taken a very complex topic, Ross, and made it digestible. So I'll let you talk about this resource.
Yeah. So this, as Megan was saying, is really geared towards clinicians, and really it's something that I wish I would have had when I was in PT school. So I think that whether that's PT, SLP, or OT students, I think could all benefit from something like this too, if you're needing to understand how diagnostic metrics work and what some of the main ones that you see both in literature and for your clinical practice, how they work. So the first portion, the first 2 pages, is kind of getting into the nitty-gritty of some of these different values. And I'll try not to get bogged down too much in some of the details, because you could probably easily talk about this stuff for a long time. And then the second 2 pages are more like a very simple, very clinically applicable sheet that we'll go over as well. So with those first 2 pages, it talks about sensitivity and specificity. And so sensitivity, the key word to remember there is that you're always dealing with people with disease. So if you look at that little table up there, the sensitivity column is on the left there. And typically to calculate the sensitivity of a test, you're taking people with positive tests who have the disease, your true positives, and then dividing it by the total number of patients with disease. So the key word to remember there is with. If you remember that, it makes it easy. And practically speaking, sensitive tests are good for ruling out. We all learned spin and snout and how a sensitive test is good for ruling out disease. Though, as we'll talk about, there are some limitations with that. And essentially, sensitive tests are good for ruling out disease, because if a person, say there's a test with 100% sensitivity, it means that it's detecting virtually everyone with disease. So that means if someone has a negative test, it's virtually impossible that they have the disease, if that makes sense. So specificity is you're dealing with people without disease. So you're looking at the next column over there. And the equation for that is people with true negatives, so D divided by the total number of patients without disease. So it's D over B plus D is your equation there for specificity. And specific tests are good for ruling in disease, because if a person tests, if the person tests positive, because a test with 100% specificity would detect virtually everyone who did not have a disease. So it makes it highly unlikely that a person with a positive test doesn't have the disease. Accuracy, I put in there because you see this pop up in the literature, and essentially it helps to differentiate healthy and unhealthy cases correctly. And so the formula for that is A plus D over the total number. So essentially it's your true positives, true negatives divided by the total number of people tested. Predictive values, I won't get into too much. I think they have more limited usefulness in clinical practice. Essentially the positive predictive value is the proportion of people with the positive result who have the disease. And negative predictive value is the proportion of people with a negative result who do not have the disease. The reason why these have more limited applicability in clinical practice is because it can change a lot depending on the prevalence of the disease in a population. So as an example, a Lachman test is it's a very sensitive and specific test. It's about 0.9 for each, which is very good. But if you're using a Lachman on, say, 100 random people from the community with no knee trauma and no swelling and no pain, even if you get a positive test, does it mean that they have an ACL tear? And probably not. And so that's why I think that your predictive values, even though you see them in research and it can be good to have an idea of what they are, it's not something you're probably going to apply to clinical practice as much. So you have your likelihood ratios, and these I think are much more applicable in clinical practice. So the positive likelihood ratio is the probability of an individual with disease having a positive test divided by the probability of an individual without disease having a positive test. So the formula is your sensitivity, and we'll go over this a little bit on the next page too, but it's your sensitivity divided by 1 minus specificity. And what makes this useful is you can take, so long as you know your sensitivity and specificity data, you can take any test and figure out how much it's increasing the likelihood of a disease with a positive test. So say someone has a positive likelihood ratio of 10, and they have a positive test, it means that they now are 10 times more likely than they were before of having that disease when you test for it, if that makes sense. So it's very much easier to apply in clinical practice. The negative, and so typically with those, you want to have high numbers. So 10 is very good. Negative likelihood ratio is kind of dealing with more of the negatives, and the formula is 1 minus sensitivity divided by specificity, and you want low numbers with this, less than 1. So typically 0.1 is a good number to shoot for with the test. That means it has a very good low likelihood ratio. And so as we'll talk about, if you have a test, say you think someone has 5% chance of having a disease and they have a likelihood ratio of 0.1, then that means that you've now taken, with a negative test result, you've taken their chance of having a disease from 5% all the way down to 0.5%. So it means it's a very valuable test in that case. Whereas if the number is higher than 1, it's basically a useless test, and it's kind of the opposite with the positive likelihood ratio. If you have a positive likelihood ratio less than 1, it's basically a useless test. So we kind of talked about the advantages there, and we could probably skip over to the next page and we'll talk a little bit about how to apply these a little bit more. So essentially you can take your sensitivity and specificity, and I was playing around a little bit with some of the Lockman data with this before we started this. And so as an example, to calculate your positive likelihood ratio, you take your sensitivity, which is 0.9, and you divide that by 1 minus 0.9, since the specificity is also about 0.9 for the Lockman, and you'd end up with a number of 9. So that means that with a Lockman test, someone's about 9, if it's a positive test, they're about 9 times more likely to have an ACL tear than if they did not have a positive test. And you could do the same thing, 1 minus the sensitivity, in this case, we'll say 0.9, divided by the specificity, and that ends up working out to about 0.11, and when, as we talked about, if you had a 5% pre-test probability, that would reduce your risk to about 0.5%. So this is where there's some subjectivity. So if you have to estimate the pre-test probability, and so there is subjectivity with this. You could also use data from studies, looking at prevalence rates, but the chances are is that a study won't have the same prevalence rates as your population, so you have to be careful with that. But as an example, if someone twists their knee, it's a non-contact injury, they have a pop and swelling, you could probably put a pretty high, just based on your clinical judgment, they might have an 80% chance of an ACL tear in that case, and so you can use your clinical judgment in that way. So this nomogram here, in our example, so we talked about, say someone has a 5% chance of having an ACL tear prior to you testing them. That's your pretest probability on the left. So if you drew a line from that through about 0.1, which is your likelihood ratio, your negative likelihood ratio, you would see how that line would work out to around 0.5% if you drew a line between the two, if that makes sense. So that's how you can use the nomogram, or you can just use pretty simple math to kind of come up with your post-test probability as well.
Well, this is one way to launch your documentation into orbit.
Yeah, and I don't think
Take
it's
it up a
something that you have
notch.
to, and I don't think it's something where you have to like take every test you do with someone. If you do 10 special tests with someone, you don't have to sit there and be like, okay, what's my chance here? It's more to kind of give you an idea how useful is this test. So if you're reading a study, there's some new test and you want to see how useful is this test in my clinical practice, you can do some of this, work through this, and kind of come up with an idea of what the chances are that someone might have a disease with or without a positive test result.
Very cool. Yeah, and it's a great way to, just double check the resources that we're using as far as assessments.
Yeah,
and make sure that
absolutely.
they're going to work.
Yeah, I love it, Ross, because I mean, it's I think when you learn this stuff, especially the first time, I think all tests are created equal in the novice eye, right? So I think that this does provide some insight to either a real advanced student or probably even a seasoned clinician in terms of what, if I got a positive on one of these tests and a negative on one of these tests, which one do I actually care more about? This is a nice resource for that.
Right. And also something else that I think with the likelihood ratios that can be interesting is a lot of times we put a lot of value in tests that have very high, say, sensitivity, but a low specificity, or a high specificity with a low sensitivity. But when you calculate the likelihood ratios, since likelihood ratios are related to both, sometimes you realize, oh, this test is, even though it has a high specificity, it's still garbage. You know what I mean? And so it can be useful to apply to tests that you use in clinical practice. Or like I said, if you see a new study with the new test, you can use that to kind of see how useful is this test in my clinical practice.
Great. Thank you. Okay, the next resource we're going to talk about, also written by Ross, is what is proximal hamstring tendinopathy. This is a 2-page resource that has some pictures, some anatomy drawings on it, and it goes over what it is, how it's diagnosed, and how it's treated. Ross, tell us a little more about this resource.
So this is designed to be a handout for people with proximal hamstring tendinopathy. It's just kind of an educational resource to help them understand their injury. So it goes into what the hamstrings are and what they're involved, that they're involved with sprinting or climbing uphill, and that this muscle attaches to your sit bone or your ischial tuberosity, and that essentially tendinopathy is when you have degeneration or micro tearing of that tendon. When you're doing, typically it comes on over time when you're doing a lot of activities that compress the tendon, since tendons don't really like compression, they like tensile loading. So this picture here with people jumping hurdles is a very good example of a position that would put a lot of pressure on the proximal hamstring tendon, with the hip being flexed forcefully and rapidly into flexion. You can kind of see how the tendon would be wrapping around the ischial tuberosity a little bit in that position. And so it talks about activities that can cause it, and then it talks a little bit about the sciatic nerve, which is just lateral to those tendons, and how sometimes swelling or irritation of the tendons can also cause sciatic-like symptoms or nerve pain type symptoms down the leg as well. Talks a little bit about how it's diagnosed, and so usually it's a combination of history and physical provocation tests. You can use imaging to rule out other issues like tears, but usually that's not necessary. And then it talks a little bit about treatment and how, unlike some of our other tendons, like the Achilles tendon or the patellar tendon, there are a lot less randomized controlled trials available to guide clinical practice with this one. But we do know that data from other studies looking at different tendons shows that infrequent but high intensity contractions seem to be optimal for rehabbing tendons and then also avoiding compression. So I really liked this illustration that was included with this, where they show a hamstring bridge, and this is a great way to load the tendon. And because the hip is more extended rather than flexed, you're not compressing that tendon into the ischial tuberosity. So you're giving it that tensile load that helps to remodel and strengthen up that tendon without giving it the compressive load that's more likely to irritate it, like during a straight leg deadlift. And it talks a little bit about that it's a long haul with any tendon issue, but especially insertional tendon problems. You're looking at least 3 months is kind of the minimum for rehab to start seeing changes, and really might be more like 6 months to see a big change. And then there are other medical interventions like injections and shockwave therapy. There's not a lot of data surrounding those at this point, but they can be options if conservative treatment isn't working. And then surgery can be used, and I think this is probably a pretty rare surgery, but that would involve releasing the hamstring tendon and sciatic nerve as well. So kind of a nice simple 2-page resource to help people with this condition kind of understand what's going on and what to expect with treatment.
Great. Yeah, and I love how it's easy to read for patients and broken up into nice sections.
Yeah.
All right, we went over this article snapshot. We've just got one more for everybody, and Troy, take it away with this one.
Yeah, great. I circled back around to this article. It's a little bit older, but we've seen some stuff that we've put together for you in the past that cites some of this material. So the article is called Strengthening and Optimal Movements for Painful Shoulders and Chronic Spinal Cord Injury. So this is a study that was done about a decade ago, but it's used a lot in both outpatient and even inpatient settings right before discharge for home programs for individuals after spinal cord injury. I think the reason that this study is used so frequently is they did a really nice job in their appendix of not only proving that these exercises are effective for wheelchair users at reducing shoulder pain, but also this appendix has really well laid out home program. So it's just like a one-stop quick way to access a home program for individuals that's really well detailed and evidence-based. So so take a peek at the big study if you want, but ultimately what it looks at is reducing chronic shoulder pain for manual wheelchair users. It involves a 12-week home exercise program. It really is meant to be done in the home. The only things that you need for this is TheraBand and some light weights. So, something that can even be modified at the home with, a grocery sack full of some items, or, the classic soup can or something like that. So it is some low load exercises, but really goes into good detail on how to do that. They looked at, I don't remember exactly, but less than 50, I think more than 30 subjects with this chronic shoulder pain, and ran them through these protocols. And really the vast majority of people had a significant decrease in their pain. And then it was nice because after the study was over, even those that had the kind of sham intervention, which was, I think, just kind of like non-specific shoulder anatomy education and things like that. That group didn't get better, but those researchers still gave them the protocol anyway. So it is a really valuable piece that I just wanted to be able to give our subscribers access to understand kind of where that comes from, and what the actual basis is for giving that. So
Great. And we have a resource in the library that outlines the protocol, right?
We do. Yeah, we do. Exactly. So this is a nice one to kind of, if you've just been using that blindly, like I feel like some of us do, this might be another thing to look back at and say, oh yeah, here, this is why this is valuable. Or maybe you're having a patient that is not really into that, the idea of a home program or something like that. You can, and you're trying to do some motivational interviewing or something along those lines of seeing if this person's going to be ready for this change. This might be a nice piece to be able to give someone that does, is maybe a little bit more analytical or wants a little more evidence behind, maybe doesn't take your word at face value. I guess this might be a nice thing for them too, to help them make a healthy choice.
Great. Yeah, and we'll link that in the show notes for this show as well. All right, that's our show for today. Thank you everybody for watching. This is actually our last episode of the Physical Therapy Resource Roadmap show. So just want to thank everybody for watching and engaging with us. If you have any questions, you can reach us at support@therapyinsights.com. Thank you.